Yeah, good evening, everyone. From Yashoda Hospital. So every Friday we bring forth interesting, relevant, and up-to-date topics in the field of emergency medicine by our experts. So this fortnight, so we are coming with an interesting topic: point of care regional anesthesia in emergency department, nothing but POCR. So for this we need the UGRA, that is ultrasound-guided regional anesthesia in the emergency department. So UGRA is a safe, effective, increasingly integrated into the ED analgesia protocol. And this evidence, as we say, in 2025, the RCT study, which was done and published, where the nerve blocks before this publication was only just 2% usage in the ED. Now, after this publication, we came to know that 52.9% after the training procedures, the usage of regional blocks in the ED is there. So of this 50% reduction of the pain is there in the patients, and the procedure taken is only 15 minutes. And there is a reduction in the delirium, especially in the elderly, and which is a fast, effective, and a safe procedure. So to talk about this topic, I'll introduce Dr. Shaini Priyadarshini, who is an associate professor in the Department of Anesthesiology at Narayana Medical College Hospital, and she is completed his head. So the floor is open to Shaini.
Thank you, sir. Thank you for that introduction. So I think sir has crisply summarized the need for focus-guided blocks in the ER. Actually, the ER physicians are perfectly placed, in my opinion, to provide the best of care, especially in trauma cases. You guys are already doing the fast and fit, so ultrasound is not something that is unfamiliar to you or us. So let's just take it one step ahead, and we have quite a lot to cover. So let's just start off with it. So like we know, pain was undertreated in the past and is the most prevalent request in your emergency room. Someone is coming with a trauma, the first complaint, pain. What most common cause that brings a patient to the ER? Mostly it is pain or loss of consciousness, like you all know. So in the past, we have relied largely on opioids and NSAIDs, but as we all know, the side effects of opioids and NSAIDs are beginning to rise. So ultrasound-guided regional blocks have started coming into play. So this is not just a one-step cure-all. Regional anesthesia is a part of a bigger concept known as multimodal analgesia. So, like we all know, pain is not just a sensory experience, it's also an emotional experience. It has myriad effects on various systems of the body. And pain can serve as a reminder of the traumatic event if left untreated or treated unsatisfactorily. So our goal is not zero pain, but it should be a tolerable amount of pain. Okay, but that should be individualized based on the patient's particular case. Okay, so you cannot follow a one-size-fits-all approach. It has to be tailor-made to that particular patient. So with ultrasound guidance, your nerve blocks, they allow the clinician for a more nuanced, patient-tailored approach. And with education, hands-on practice, it can become a very integral aspect in the analgesic armamentarium. So blocks, they are divided into different levels based on their simplicity. Or rather, I can say, as you go from the periphery to the center, you need more level of expertise. So with practice, I'm sure all of us can do that. So a brief, quick 5-minute refreshment on how the physiology of pain is transmitted. So the injury, transduction, transmission, perception, and modulation. We all know this right from our MBBS days. So where does the regional anesthesia act? It acts on the transmission of pain. So like we all know, this inadequate acute pain management Could be due to the lack of concern, could be due to inappropriate use of drugs, and a lack of a multidisciplinary approach. So we all know the harmful effects of pain. Let's just refresh through them. First, a lot of pain can suppress the immunity. It can reduce the wound healing because pain will stimulate the cortisol and all other metabolic, catabolic hormones. Then there is an increase in the metabolic demand. There is an increase in the blood sugars, and there is a hyperthyroidism. In the lungs, if their patient is suffering from abdominal pain, he can have impaired lung function, especially in a case of a rib fracture or an abdominal trauma. The patient cannot breathe fully. So the base of the lung will go in atelectasis, and there'll be a decrease in the functional residual capacity. So the effects on the heart are stress response, hypertension, and a possibility of MI in patients who are already compromised. So this leads to a displeased patient with delayed mobility and poor patient cooperation, especially during shifting. Whenever you want them to do a further assessment, a patient in pain is not a very good patient. I'm sure we all know that. And post-traumatic stress disorder and low quality of life. Okay, so before going into that, let's discuss pain assessment. There are various scales. This is the numerical rating scale, the visual analog scale, defense and veterans pain rating scale, behavioral pain scale, clinically aligned pain assessment tool. Then this FLACC is the pain score that is used for children. Right. Analgesic methods. So we all know that the recent concept is multimodal analgesia. That is, we just discussed the different pathways of pain, right? The transduction, transmission, modulation, and the perception. So we choose an agent that acts on each pathway of the pain. Okay. So multimodal analgesia will have a pharmacological component, but in ER, I think it is difficult to go through. But just for the sake of the completion of that term, multimodal analgesia, I've added this slide. So let's just concentrate on the pharmacological ones: opioids, NSAIDs, muscle relaxants, antiepileptics, NMDA antagonists, which is your ketamine, alpha-2 antagonists, all of these, and regional blocks. Yes. So the advantages of on-arrival blocks, like you all know, effective pain relief gives you stable hemodynamics. If the patient is in pain, the BP shoots up, the heart rate shoots up, and it is difficult to ascertain whether it's because of the pain or due to some other cause. So it helps the clinician, at least differentiate between the different causes. And if you're able to place a catheter, it can provide extended analgesia for 2 or 3 days. Yes. A patient who is comfortable will give you a good history. So the facilitates history extraction and examination, relieves anxiety and stress, and early intervention if possible, minimizes the opioid consumption, and there are minimal side effects. So, yes. So the purpose of these on-arrival blocks. Hello, am I audible? Yes, let's continue. The purpose: immediate pain relief, which improves the patient cooperation. Continuous regional anesthesia with catheters renders superior analgesia, especially for patients with rib fractures. It improves the diaphragmatic function, and if you have put them on a ventilator, or if the patient, it helps to wean them quicker. So avoids administration of major opioids or longer duration of opioids, which can create difficulties during the assessment phase. A tourniquet can be applied without causing pain before the initial dressing is removed in anticipation of massive bleeding. So, right. So pain-free detailed clinical evaluation of the injury, calm and cooperative patient for shifting and imaging, compliance for sending lab investigations, and sometimes it can even be used for definitive surgery. For example, if there is a fracture in your ankle, and if we are able to do a good popliteal sciatic block, that block can be continued for surgery as well. So that is the advantage. But before doing the blocks or per se, we need to follow certain standard procedures. Like for every medical procedure, we have to take a informed consent after discussing the possible risks and benefits of that particular procedure. Okay. We have to follow our regular aseptic universal precautions, especially sterility of the probe also. That has to be taken into account. And all those blocks will be performed with an IV line in situ and monitors attached with the ECG, because there is always this possibility of last due to inadvertent injection of the local anesthetic into the bloodstream. Okay, so we need to have trained personnel, the availability of the ultrasound machine, and proper counseling. Okay, so the different blocks that can be performed, we are going to have a look at all these blocks in that particular order. So yes, a few words on pre and post block before going into the blocks per se. So for any block where you're going to administer more than 20 ml of local anesthetic, it is advised to follow a 2-person technique. Okay, so one person will handle the needle and the other trained personnel will administer the drug. And when you are doing a facial plane block or any block that is closer to the neuraxis, for example, the interscalene block or block with where your vascularity is very proximal. For example, your axillary block, we will always hydrodissect, that is, inject a few mils of saline prior to injecting the local anesthetic. So these are the guidelines for nerve block safety. So pre-block setup, I think we have to always make sure the patient doesn't have a coagulopathy or he's not having any allergies to local anesthesia or any neurological deficits. So if there is a neurological deficit or a potential for it, a full neurological examination should be documented in the patient's medical record prior to the nerve block. This includes the presence of peripheral pulses, arterial pulses. So if a fracture is present and an orthopedic intervention is necessary, it is advisable to discuss with the orthopedic consult to ensure that it doesn't change their management or interfere with that. Okay, so like I said earlier, have the patient with the ECG running to assess for LAS, local anesthetic systemic toxicity. And everyone should know where the lipid emulsion is placed or where it is under lock and key. And before doing the block extremity, the block site, and the dose should be confirmed with a 2-person verification. Okay, so these are the commonly used regional anesthetics in the emergency setting. So commonly used drugs are lidocaine, bupivacaine, ropivacaine. In India, we have levobupivacane and ropivacaine, which have a longer duration of action compared to lidocaine. So I would recommend levobupivacane 0.25% or ropivacaine 1%, depending on the patient's body weight. So you have a look at the doses. So post-block, it is important to repeat the neurological examination and note it down. You note the timing of the block, right, and make a note of the volume and concentration of the drug used, the site, and if there were any potential complications that were encountered during the procedure. Okay, so without further ado, let's just dive into the blocks as such. So the upper limb blocks, the entire upper limb is innervated by the brachial plexus, which we are quite familiar with, and they provide effective pain relief for shoulder, arm, forearm, and hand injuries. But the brachial plexus needs to be blocked at different levels. So these terms that interscalene, supraclavicular, clavicular, axillary, individual nerves, all of these, they're just points or places where you need to block the brachial plexus. As you all know, brachial plexus is formed by the ventral rami from C5 to T1, and it joins, forms roots, then forms the trunks, then divisions, then again joins to form the cords, and then terminates into the different branches which supply different parts. So easy way to remember is your interscalene is helpful for your shoulder, more proximal, up to down. Interscalene is useful for the shoulder, clavicle, supraclavicle for your arm, all above the elbow and below the elbow also. So axillary, predominantly elbow and below the elbow. And costoclavicular is another approach to the brachial plexus at the infraclavicular level. Why I have mentioned this block is for a supraclavicular block, you may need to give 4-point or 5-point injection. It's a multi-point injection, whereas for your costoclavicular, it is described to be a single point injection. So it may be a bit tricky in the beginning, but as you keep doing it regularly, it is very easy to do it. So this is a picture where showing the dermatomes, myotomes, osteotomes. So knowledge of that is important when you are doing the block, because for a fracture, so the concentration, for a minor laceration, the concentration of the drug and dose may vary. So the interscalene block, I think the procedure per se, let's just, you know where the probe is placed, and and you have to locate the anterior scalene muscle and the medial scalene muscle, and the needle is placed from lateral to medial between the C5 and the C6 nerve root ideally. But many times the anatomy keeps varying from patient to patient. For some patients with a short neck, a volume as much as 5 ml may be sufficient for analgesia, whereas in a patient with a long neck, 10 ml may not be sufficient. So it depends on the patient's individual anatomy and at what level they are forming the nerve roots. So the problem with the interscalene block is that there is a possibility, almost a 90% possibility of a phrenic nerve block if not done properly. That used to be the case when it was done blindly. But now with the advent of ultrasound, the incidence has come down, but it has not been eliminated. I wouldn't say it has been eliminated, but we can control the volume and the concentration of the injectate. So another example, so if you want to do a shoulder reduction in the ER, an interscalene block would be the block of choice. Or rather, nowadays, people are practicing the superior trunk block. Your superior trunk is the place. See, now you can see the C5 and C6 as separate entities at the interscalene level. If you slide the probe just a little bit distal, you can see the C5 and C6 joining to form the superior trunk. So at that level, giving a block would decrease the incidence theoretically theoretically decrease the incidence of a phrenic nerve palsy, right? So yeah, I wanted to present this diagram, this schematic representation. So look at the trajectory of the block needle. Look at the presence of the prevertebral fascia. Ideally, I would recommend the block needle travel and just stay there. Stay right near the middle scalene. Don't pierce the prevertebral fascia. I know it is very difficult in the initial days, but as you keep doing it, you will get better at it. Because one more thing is, we know that the fascia is not it's not an impermeable structure. It is a porous structure. Invariably, in the due course of time, the drug is bound to diffuse. But limiting your block needle to this area, to the middle scalene, and allowing the drug to potentially spread down in the groove is a better approach. So let's go more distally. Now we've come to the supraclavicular. It was earlier described as a bunch of grapes. So just look, you'll have multiple nerve rootlets around your subclavian artery. So just place your probe right above the clavicle, looking down into the supraclavicular fossa. Please use a color Doppler to identify the presence of potential vascular elements, because there can be a dorsal cervical artery or a transverse cervical artery in the mid masquerading as a nerve. So unless you turn on your Doppler, it is very difficult to identify that, because the nerve roots at this level, they are covered with very less of that peripheral fibrous sheath. So as the nerves travel more distally, there is more connective tissue being added around the nerve sheath. So that's why you get the typical honeycombed appearance in your distal nerves. When you go and scan your median nerve or ulnar nerve, you can find the typical honeycomb appearance. That is due to the presence of more connective tissue, as the nerves need more protection as they go distally. So here, it is very easy to confuse the nerves with an artery. So these are, please turn on your Doppler before doing this block. Right. So the costoclavicular block, if you look at the schematic picture, your cords are arranged quite compactly close to the axillary artery and the axillary vein. Here, your probe is placed below the clavicle, looking up slightly. So you will identify the nerve roots. If you can see in the real ultrasound picture, the plexus is looking a slightly little bit like a honeycomb. So it is very easy to go out of plane and give this block. So this is a bottleneck where all your cords are compressed together. So single point injection of 20 mils of drug will give you the desired effect. So this is very useful for all the blocks below the shoulder. Yes, so the interscalene block would provide excellent analgesia, but there is a risk of phrenic palsy, superior trunk, lower risk. Okay, so we are all very much familiar with the supraclavicular because it was simpler to do. So now with the advent of ultrasound, we can do different modalities, whatever you are comfortable with. Right. Next comes further down is the axillary block. So the axillary block, two catch points are, it's a very vascular block, and the nerves are all separated into their individual components by this time. So you will need to be blocking, make sure you're blocking the median nerve, the ulnar nerve, the radial nerve, and the musculocutaneous nerve as well. Primarily, we do the axillary nerve block for all the procedures below the elbow. It is supposed to give good analgesia for all the procedures. For example, there is a tendon injury or there is a laceration that needs to be sutured. The axillary block was done blindly all this while, but now with the advent of ultrasound, it is very safe. You need to be careful while injecting, and you need to keep aspirating every 3 to 4 mils to make sure you're not directly injecting into the vessel. That is one place where you can get a last. There is a possibility of last. And be careful with the dosings with elderly and young. So yeah, more of the same. Just look at the needle placement. Look at the second, look at the needle being placed in the musculocutaneous nerve. The musculocutaneous nerve is not in the axillary sheath. It needs to be blocked separately. It is within the biceps and the coracobrachialis. So that is one point to note when you're doing an axillary brachial plexus block. Next, I wanted to mention stellate ganglion block along with it, upper limb blocks. So your stellate ganglion block is basically, it is used in chronic pain and in acute, in the ER, I think you can use it for refractory VTs, ventricular tachycardias. Basically, it is a cervical sympathetic block. So it blocks the sympathetic accelerator fibers to your heart. So the location where you do it typically safely is your C6 tubercle at the level of C6. So the picture you need to be looking for in an ultrasound is the carotid artery, the IJV, and the transverse process and the anterior tubercle of the C6. So let me, it's very difficult. Okay. So, but it's very important to scan the stellate ganglion before the block to determine your needle path, because many of the times the esophagus is also lying nearby, especially on the left side, if you are supposed to do. So usually you do it on the left side for a reflectivity. So the needle path, if you look in the second picture, it is between the carotid artery and the longus colli muscle. So your needle path needs to be very important. Okay. Hello?
Can I adjust the camera?
Camera.
Yes.
Is it okay now?
No, ma'am.
You can't see?
Yes, little bit like sir.
Okay, okay. I can't see myself.
Yes, ma'am. Now it is okay, ma'am. You can share your screen, ma'am.
Okay, right. Sorry for the interruption. Yes, so the needle pathway, you need to make sure it is not through the esophagus, right? So pre-scan is important in planning the path of the needle insertion, as the presence of the esophagus and the inferior thyroid artery may obviate the needle insertion path between the carotid artery and the trachea. In that situation, the needle may be inserted lateral to the carotid artery. So the indication in ER is refractory VT. Okay. Nerve blocks so we are done with all the blocks at the level of the head, neck, and axilla. And now we come to the individual nerves. Individual nerves, they can be blocked above the elbow, below the elbow, depending on where your target site is. So nerve blocks above the elbow, this is where you give your radial nerve blocks. I know it is a bit difficult to just show you a static image, but I would prefer a dynamic image to show you the nitty-gritties. But just let's quickly brush through the theory. So it is, instead of wrist blocks are no longer recommended. They are very easy to do as a blind procedure, but at the level of the wrist, there is always a possibility of nerve injury with your thin needles. So I would recommend you to do the individual nerve blocks where they are embedded in between the muscles. So you have the muscle guarding, so you don't have the possibility of injuring the nerve. So this is where you do your radial nerve, the ulnar nerve, the median nerve. The median nerve is located quite close to the brachial artery at the just above the elbow level. Okay, right. So you can always scan these nerves from proximal to distal or distal to proximal. So you make sure they are what is what. Okay, so you can practice scanning on your regular patients also if you have the time and opportunity. So you can get better at identifying them. So median nerve at the level given below the elbow is between the FDS and the FPL. So this is the schematic. This is where you give the radial nerve block. So for the radial nerve, the problem with the radial nerve block is it needs to be given as high up as possible for you to cover all the possible branches, because the radial nerve starts dividing quite high. It starts dividing, giving off superficial branches just above the elbow itself. Yes. So the next slide. Yes, so this is where you block your radial nerve at the level of below the elbow. This is where you block your ulnar nerve. Ulnar nerve is always found beside the ulnar artery. Moving on to the lower limb blocks. Yes, so the most popular nerve block of the lower limb is your femoral nerve block, right? So the femoral nerve, it innervates the hip, and it divides further down, and it gives your innervation all the way to your ankle in the form of your saphenous nerve. So your most common population that come with hip fractures are the geriatric population who present with hip fractures, mostly due to falls. So it could be a trochanteric fracture or the fracture of the neck of the femur. Irrespective of the time of arrival to the hospital, every hip fracture deserves a block immediately. So like Sir said earlier, old age population, they are the ones more prone for delirium and all that. So you can reduce your opioid doses by giving effective analgesia. So with the advent of the ultrasound, it's much more easier to give a femoral nerve block. So you already know it can be given without the USG. So it's useful for hip, femur, tibia fractures as well. So if you look at the schematic diagram, your femoral nerve is enclosed within the layers of your fascia iliaca. Fascia iliaca splits into two, encircles the nerve, and then continues above the iliacus muscle. It is not in the same sheath as your femoral artery and femoral vein. So this is important because that's how your fascia iliaca block works as well. That's how it covers your femoral nerve. So PEN block. So this is a pericapsular nerve group block, And the founder of this block was also Dr. Philip Peng from Canada. So this this block has been quite popular of late. It supposedly covers all the articular branches innervating the hip capsule. So how do you do this block? So this is the picture to identify on the ultrasound screen. This pelvic rim, the continuous bone, and you need to be giving this block beside the psoas tendon. If you look at the schematic, you can see the psoas tendon as the white structure, and it is sitting above the iliopsoas notch, right? So just your needle can be placed. Once you hit the bone, inject up to 20 milliliters of local anesthetic. So this is an example of a fascial. It's not a fascial plane block, but it's not a nerve block either. So you're blocking all the articular branches of the hip. So it is supposedly blocks not only the femoral nerve, the obturator nerve, and the accessory obturator nerve as well. So the quality of analgesia is much better than just a femoral block alone. So it helps you, so the patient can actually sit once this block is established. Yes, like we discussed earlier, we know what the fascia iliaca is. The fascia iliaca compartment block is simply depositing local anesthetic in that plane. So using the ultrasound, visualize the femoral artery, femoral nerve, the iliacus fascia, and it supposedly blocks 3 nerves, but the authenticity of it blocking the obturator nerve it's kind of controversial. But we know for sure it blocks the femoral nerve and the lateral femoral cutaneous nerves. Next, the other major nerve supplying your leg is your sciatic nerve. The sciatic nerve, femoral, saphenous, all given combinedly will be very helpful for femur, tibia fractures, which are very, very painful, as you all must know. So ankle blocks are given for foot injuries. So sciatic nerve, it can be blocked at various levels depending on what fracture it is. So for a tibial fracture, blocking it at the subgluteal level would suffice. For a fracture below the medial malleolus or the ankle, blocking it at the popliteal fossa would be sufficient. So let's have a look here. So this is the proximal sciatic nerve block at the subgluteal level. Okay, this is quite easy to perform. You just need to identify 2 bony prominences. One is your ischial tuberosity and other is your greater trochanter. So place your needle between the quadratus femoris and the gluteus maximus. So it's quite easy to identify it as one of the largest nerves, and it's a very big pocket. So it can be safely done. But here's the problem. For this block to be done, you need to keep the patient in a prone position. So it's not possible always to be done. So that is the reason anterior approach to sciatic nerve exists. But this is a very deep block and it's quite difficult. The patient may be quite, experience some pain. But this approach has been described specifically for patients who cannot be turned to a prone or even a lateral position. So if you look at the cross section of a cadaver, you need to be using a curvilinear probe for this. That's why all the blocks we discussed with it suffices to have a linear probe. But for this approach, we need a curvilinear probe. So if you look, you're placing the probe quite anteriorly and quite laterally. So the patient is not fully supine, but slightly turned laterally. So your nerve block needle, you need a 15 centimeter needle or a 10 centimeter needle for this approach. So your nerve is between the adductor magnus muscle. Okay. Yes. Right. Next, this is the popliteal level sciatic nerve. The block. So for this, the patient needs to be prone or lateral, and place your probe at the popliteal fossa level and try to scan up and down, where you can appreciate the nerve joining together or splitting together, and you can deposit your nerve in the paraneural sheath. So ankle blocks, instead of, ankle blocks, traditionally we were doing 5 blocks, 5 different injections at 5 different points. So I would suggest rather we can try giving a popliteal level sciatic nerve block, because all of our nerves are essentially branches. All the 4 of the 5 nerves are essentially branches of the sciatic nerve. So we can give blocking it at the popliteal level. We'll finish it off with a single injection. That is my opinion. You can do whatever is comfortable for you. The other nerve is the saphenous nerve, which you can block at the adductor canal level, or you can just simply give a subcutaneous infiltration at near the saphenous vein. So yes, so after discussing the blocks at the upper limb and the lower limb, now we move on to the chest and the trunk. Okay, so chest injuries, effective analgesia for patients with rib fracture is the primary goal. Okay, so there are several options available, but your level of expertise should matters while performing these blocks. So goal of the therapy is to minimize respiratory depression and optimize respiratory excursion. So I'll just discuss all the modalities. So the thoracic epidural, but it may be, but there are a lot of risks associated with it. Then comes your paravertebral. So paravertebral also, it's technically a challenge. It's a level 3 block. It's technically challenging, but it provides, it's as good as a unilateral epidural. So the risks with ultrasound are minimal, but there's always a risk of pneumothorax, hypertension, and vascular puncture. Okay. And then next comes your midpoint transverse process to pleura block. So here you are depositing the drug between the midpoint of the transverse process. If you look at the schematic diagram and at the green line, they have marked the distance from the erector spinae muscle, the paravertebral space, and the midpoint of the transverse process. So that is where you are depositing your drug. The idea is that all your facial layers, they're all porous and permeable. Your drug will travel through them through diffusion. It will just take a little bit time. The drug percolates to the septations and the fenestrations in the superior posterior transverse ligament into the paravertebral space. So it's just an easy way of doing your paravertebral block without all the risks. And then comes the block of the century that has been much discussed, and we all need to be knowing this block is the erector spinae block, right? So it can be given for unilateral rib fractures, posterior rib fractures. You can safely place a catheter, and the chances of hypertension are quite less, and it is also said to be safe in coagulopathy. So, and remember, when you're doing this block, the endpoint is hitting the bone. So you're sure you'll not be hitting the pleura or a vascular structure. So if you look at the upper thorax level, at the level of the scapulas, so you will decide your level of erector spinae block depending on the ribs fractured involved. Depending on the number, you will decide your level. So look at the structure: skin, subcutaneous, trapezius, rhomboid. The rhomboid muscle will be seen only in the upper part of the thorax. Okay, as you come lower towards your lower thoracic spaces, the rhomboid muscle will start disappearing, and you will see only 2 layers, only the trapezius and the erector spinae. So your end point is to lift the erector spinae muscle off the transverse process. So as soon as you put your needle here, hydrodissect with 2 to 3 mils of saline, you will see the space opening up. Once you ascertain that, please inject at least 20 to 30 mils of local anesthetic, depending on the number of dermatomes you need to cover, and your block can be done very well. So this block has been described as block of the decade, I suppose. For the past 3-4 years, everywhere you turn, there has been this erector spinae block, and usually, if a single shot block can last from 4 to 5 hours. So if you want, or you're planning analgesia for much longer time, it is better to place a catheter. So next come your intercostal nerve. These are very simple to perform, and all of you must be doing it blindly also. But trust me, do it with the ultrasound. You'll be safe and more happy to do it. Okay. So, but one catch point with your intercostal nerve blocks, the area that you inject is highly vascular. So the possibility of local anesthetic absorption is very, very high. So injecting drug in the intercostal nerve space or the paravertebral space is as close to injecting in the intravascular space. That's what many of the stalwarts and experts say, because that's their experience. So for these patients, when you are planning this block, you need to be mindful of the total dose of local anesthetic administered and the concentration. The concentration also matters. So administering a large volume of a low concentration is enough to do the trick. So the risk of pneumothorax is there, although you do it with an ultrasound, because the pleura is quite close by. And if there are multiple levels, you will be requiring multiple injections. Then comes the serratus anterior plane block. This is also a very good block, and it helps if you can learn and understand this. So the risk with pneumothorax, the advantage is that the risk of pneumothorax is decreased. Okay, so look at the schematic picture. You can use it for unilateral rib fractures and anterior rib fractures. It's easy to perform as it's a very superficial block. It's quite safe in coagulopathy, and it can also place a catheter and extend the duration of analgesia. Problem with this, it doesn't work with posterior rib fractures. So if there's an anterior rib fracture and it's unilateral and you want a prolonged analgesia, you can happily place a catheter and use and prolong the analgesia as much as you want. So the location to give it is between the latissimus dorsi and the serratus anterior at the level of the 4. This is at the level of R4 and R5. So look at the schematic, look at the probe position. Like I said, it is beneficial for anterior rib fractures. Okay. So yes, in a case of polytrauma, it's always important to be mindful of the dose, and you should not delay the resuscitation just for the sake of performing a block. Okay. So disadvantages, let's discuss this. Sorry, there's a misplacement of the slide. We'll discuss this later. Let's discuss the blocks of face and neck. It's difficult. It's a difficult block to place. Your maxillary, mandibular, ophthalmic branches. These are all branches of cranial nerves. So the innervation is diverse. In facial fractures, it has to be an individual call. If there is an abscess or if there is a swelling, it is going to be difficult and pointless to place. And when you are injecting if closer to the foramens, you have to be mindful of the dose. There's possibility of nerve compression also. Okay, so let's go through these very quickly. Right, so ear block, it can be performed for ear lacerations, minor earlobe repair. This is just a 4-point injection, which was done earlier. Okay, yes. So these are the supraorbital, infraorbital, and the mandibular nerve blocks. So look at the sensory area that is covered. So these are all, like I said, you just need to look for the foramens on the ultrasound and place your needle. Make sure you use a blunt tip needle with a short bevel, especially on the face. And volume should be as much as required. Only limit your volume to 2 to 3 mils. So the analgesia is performed because the area you're injecting is very narrow. So this is where your supraorbital covers. Infraorbital, that is the sensory area covered. And this is the mandibular nerve block with the sensory area block. Right. Then comes the block of the recurrent superior laryngeal nerve. So this is quite important when you're performing emergency tracheostomy or an awake intubation, or when you need to do some procedure, invasive procedure. So the probe here, it's placed in the sagittal manner. It's not in the midline, it's in the parasagittal. So you look for the thyrohyoid muscle, look for the bone, and you can see the superior laryngeal nerve beneath the thyrohyoid muscle. Right. Sorry, I had forgotten to mention the superficial cervical plexus nerve block. The slide is missing. So I'll just explain it based on this picture. So the superficial cervical plexus, it's a combination of the 4 nerves, the greater auricular, transverse, cutaneous, supraclavicular, and the lesser occipital nerve. So blockade of this will help you to do an IJV cannulation. It will help you with your clavicular fractures, and it will help you to repair minor lacerations in that area as well. So superficial cervical plexus, it can be done under ultrasound. You just need to place 2 to 3 milliliters of local anesthetic underneath the sternocleidomastoid muscle. So with this, I think I've covered most of the blocks, and we need to be discussing this multimodal analgesia before we conclude. So like I said, the different pathways of pain and the different drugs that act on it. So if you look at this multimodal trauma pain approach, on the x-axis, you have the arrival length of your ED stay, and you have the pain severity on the y-axis. So if the pain is mild and he is only in 6 hours, NSAIDs. So as the length of stay and the severity of pain increase, you need to be looking at multimodal approach. So your peripheral nerve blocks will dramatically reduce the consumption of opioids and all other drugs. You simply need to supplement with a paracetamol or an NSAID if your block is very good. So thereby, you will be preventing all the side effects associated with these drugs. So to summarize, so on-arrival blocks, that's one way to call them. It has gained wide popularity. The multidisciplinary approach, it reduces physical impairment, optimizes functional recovery, improves patient experience. So USG regional blocks are shown to provide quality pain relief with excellent safety profile. And these are part of multimodal analgesia. And these are my references. So I thank you all for your patient listening, and you can ask me if there are any doubts or anything else if that needs to be answered. Thank you.
That's a wonderful talk by Dr. Shaini. So I want you to emphasize on last.
Okay. Yes. So local anesthetic systemic toxicity is quite tough. It's very important, especially when you're injecting close to an artery and you have to know where your 20% lipid emulsion is placed. So before doing the block, everyone must know for the timeout where the lipid emulsion is placed, what is the dose. It is 1.5 milligram per kg body weight, and how it has to be given. First, before that, everyone needs to be familiar with the signs and symptoms of LAST. Okay, that is the reason I insisted on a monitor being placed before the blocks were being done. So first, so depending on the drug, bupivacaine has shown the highest potential for cardiotoxicity. But now with the advent of levobupivacaine, that incidence has come down. The problem with these local anesthetic, they don't just block the sodium channels. They also go and block the calcium channels. They also go and block all the other channels in small proportions, but they are the reason why we have these arrhythmias. They go and block the potassium channels as well. So that is the reason we have arrhythmias. That's the reason we have neurological manifestations. So with lignocaine, the incidence is 7:1. So you get more of a neurological complications before the cardiovascular complications. So neurological symptoms, they may appear as tingling, perioral numbness, and by this time we should be able to identify that the patient is showing symptoms of LAST. So you can you can reduce the seizure threshold by administering lipid emulsion and preventing cardiovascular toxicity. Anything else?
And compartment syndrome.
Compartment syndrome, yes, sir. So it is a bit controversial, sir. If you look at the literature, there is a lot of literature before the advent of ultrasound. So before the advent of ultrasound, how the blocks were being given, we all know, blind blocks. The volume was not controlled, the dosage was not controlled. But after the advent of ultrasound, the dosage is reduced. We can reduce the concentration of drug. But this has always been a point of controversy from the orthopedician side and from the pain relief, the ones who do the pain relief. So we can try reducing the dosage and the concentration. what the literature recommends is monitoring of the intracompartmental pressure. That is more, and also the keyword is pain out of proportion to the injury. So it's most commonly seen with a tibial fracture. So it's best to discuss with your orthopedic colleague and go as a combined approach with careful monitoring of the intra-compartmental pressures. That would be the final recommendation, but it depends on your rapport with your colleague and all of that. And I would recommend a very low concentration, sir, very low concentration minimum and frequent neurological assessment. So that should be the way to go.
And infection control practices during these procedures.
Yes, sir. Yes, sir. Sterility, universal aseptic precautions for the one administering the block and also for the probe. The ultrasound also needs to be sterile, covered with a sterile probe, and also the gel. Nowadays, they are available in sterile packets as well. So they need to be followed. And if you're not able to use gel, we can just use some other medium like betadine or chlorhexidine. There just needs to be a contact point. Yes, sir.
Okay. So we see if any questions are there from the audience.
I'll stop screen share.
Yeah. So if there are any questions, from the audience, they can ask. If there are no questions, we'll try to wind off. So thank you, Dr. Shaini, for this wonderful insights of regional anesthesia in emergency department by the ultrasound guided. So this is an emerging thing for the ED physicians for the pain control, whereby we are minimizing the usage of opioids and later on preventing the complications. So of late, we have seen a dramatical increase of these usage from 2.2% to 52% of usage of these nerve blocks in the ED, whereby it is almost coming to 50 to 60% of the pain reduction in the year, and which is helping more of the geriatric patients where we are avoiding these unnecessarily opioids or the short GS.
Thank
So
you.
if there are no questions, so we will wind off. Thank you, Shaini, for this wonderful insights. So every week, Friday, we bring up with fortnight interesting, relevant, and up-to-date topics in the field of emergency by emergency physician and by the experts. And I thank Yashoda Hospital, Temi and Anbai for giving this opportunity to present this. So if there are no questions, we'll wind off. Thank you and good night.
Thank you for this opportunity.
Yeah, thank you.